everyone for joining us. For those of you who are joining us for the first time, iCHORDS is a community of practice whose goal is to connect people who work in the social and behavioral sciences field of neglected tropical disease. One way in which we promote our community of practice is through our monthly knowledge cafes. During the session, please feel free to put any comments or questions you have in the chat, and we will address them in the discussion portion of the session. I'll pass it over to Alison Quentel, who will introduce our session moderator as well as our speakers.
Good morning, good evening, good afternoon, people all over the world. Welcome to the session today. This is our second in a series on never treatment. So for those of you who joined us in December, we had a session on Africa, and we had two speakers who highlighted the issue of never treatment within the African region. Today, we're going to be focusing on the Southeast Asian region with a speaker from India and from Nepal. And so it's my pleasure to introduce our speakers today and our session moderator. So our session moderator is Dr. Aya Yajima. She is the Regional Advisor for Neglected Tropical Diseases at the World Health Organization and based in Delhi. So welcome, Aya. Thank you for being our moderator today. And our first speaker will be Dr. Nirmala Sharma, who is the country coordinator in the FairMed Nepal program. She has many years of experience reaching out to the unreached and never treated populations in Nepal and strategizing actions and identifying who's been excluded from the MDA campaign. And we'll also hear from Rajshree Das. She is the Senior Director at PCI India, and Rajshree leads the project Social Mobilization for LF and VL in India, which is supported by the Bill and Melinda Gates Foundation. And it's a pleasure to have you all here today, and I really look forward to your presentations. So I believe we are starting with Nirmala. So over to you, Nirmala.
Okay. Thank you, Alison. Good morning, good afternoon, and good evening to everyone. Thank you, Alison, for giving this opportunity to share our experience in larger forum. So I start from now, like reaching the unreached, we say, but it's reaching the untreated population, because we have this community-based health programs, and then we say reaching the unreached, because we go to the first unreached population. So this concept we apply to LFMDA also. So our first effort is to ensure why we reach to the unreached is to ensure medicine access during mass drug administration campaign for LF, because like just going and giving the medicine, distributing medicine, people don't come. So people who are in far away or who are never heard about, they can't access. Okay, next please.
Varsa, are you having difficulty sharing because it's not on slideshow? So
yeah, it's quite small.
Okay, Varsa, we were having an issue earlier this morning, so I will share my screen. I think will make it easier. Sorry about that, everyone. We just we'll bring that forward right now. Sorry about that. Okay. Yeah, okay, I will go ahead and share here. So here we go. Thank you for your patience. Okay.
Yeah, but it's still small. Eh?
That should be.
Is it?
Is that better?
Yes.
It's not on
yes,
slide
now
mode.
it is on slideshow mode.
Okay, go ahead, Nirmala.
Okay, now next slide.
ठीक है रोहित रैंडम गिनेगा सब चीज को
Never treated population. We are talking today about never treated population. Who are they? They are workers, means factory workers, brick clean, daily wage laborer, and travelers who don't stay in one place, who keep on moving. And then another is urban population, residents, shopkeepers, bank and office employees, so-called educated people, and then socially, economically higher rank, they think that they don't need it. And another is person with disability, persons who are suffering with chronic illness. This one is covered with this. I can't see. Alison? Oh, yeah. Persons with disability who are confined to house, and then chronic illness and senior citizens. They are also confined to house. So another group is seasonal in-country migration and foreign employment. Those people who come to another district, another village, and then those who go to India or any other country. They are also never treated population. And then another is landless community, just like people who keep on moving from one place to another place. And then certain caste and ethnic groups in Nepal who also do not access the service, and they are never treated. They are Dalit, Tharu community, Madesi, Muslim communities, and others. Next. So why never treated? So I also wanted to share why never treated. It's because of lack of awareness, because of the perception of being in low risk, and then conception about MDA drug, that it may kill the person, I may die, kind of misconception. Another is fear of drug and its side effect, and unavailable during MDA campaign. Certain persons are not available during the MDA campaign days, and taking routine medicines for chronic illness such as diabetes, hypertension, and also feeling of being too old to take MDA. These people, they think that because I'm already taking certain disease, certain medicine, so I should not take it. And not present during household visits. When health workers visit household to distribute the drugs, they are not present. And then mobility restriction and low decision making power, especially women in our certain communities in Madhesh, in the borderline, women are restricted from going out, so they are also not treated. Inadequate on-site supervision by health workers. The health workers do not do the adequate supervision, due to different reason, and therefore is compliance gap. And waiting for advice from family physician. Those people, especially rich people, the business, from the business community, they have their family doctors, and they wait for the family doctor to show the go ahead signal, otherwise they don't take it. And influence of certain religion, like orthodox people, like Hindu religion, Muslim religion, any other religion, there are some orthodox people who don't take. Next page. What is the title? I couldn't see. And how we identify them? We identify through mapping of left behind communication during community during our micro planning. And we also explore population with special characteristic, as we defined in the previous slide. There are special characteristics, and those people we need to identify where are they, and and then we need to plan our drug distribution activities accordingly. We need to map out where are they, because we can't expect them to come to the booth, drug distribution booth, but we have to go. So we map and we identify, and then we go. And another is identification of population cluster with low MDA coverage, and this also we do during the micro planning. We identify which cluster the low coverage was in previous round, and then collecting information from health workers and female. Those things we collect information from health workers and volunteers. And then another never treated population are school students, especially hostel residents, madrasa students, bank staff, hospital staff, army, police, security force, and then traditional healers and business person. These are the particular group of people who are not treated because of, as I explained, their misconception, their feeling of low risk, being at low risk, And like this drug distribution, a drug is given on free of cost, and that is below their status, like this kind of thing. So next, yeah. And how we did it, like we strategized our MDA campaign into 3 phases. One is before campaign, at least 2 to 3 weeks before campaign, and then during the campaign and after the campaign. We have to do all these three level of awareness. Like before the campaign, there are certain type of activity like mass awareness, and then health promotion activities, every village, those with low coverage, and social media campaign advocacy with political and professional organizations and individuals, and coordination and mobilize district level stakeholders. That is very important. The government's district level structure we need to coordinate with and then mobilize them, because unless they are mobilized, people are not going to take the medicine. And during the campaign, we do on-site supervision and spot camp compliance, and then we mobilize LF affected person as a role model. We identify some LF affected persons who are the motivator to others. They say, like, if you don't take the medicine, you will be like my, you'll have my, like my case. So, and then mobilizing social influential people like Maulana in Muslim community, and LF affected is already said, and teachers, doctors, and local social leaders. They are all people who are influencers in the community. And so we need to mobilize an MDA booth in strategic locations. So MDA booth also, we identify which is the strategic location that people come and take the medicine, like bus park where people's mobility is quite high, and border operating point in between Nepal and India. A lot of people come and go, and school orientation and mobilizing teachers in unreached communities. So during the campaign, we do this thing, and then after the campaign, we go for post MDA targeted follow up in unreached household and community. We have the list of the people who have taken the medicine, and we identify who have not taken. So right after the campaign MDA day, then we send our the government health workers or our social mobilizers to reach to that house and then give the medicine. Administer supervision coverage tool in selected sites at household level to find missed out individuals and families. There also we try to find out who is missed out from this particular locality. Okay, next. So there are certain innovative initiatives we have applied to reach the unreached. One is that we share the news story about deported migrant workers from countries like Malaysia after diagnosis. Because these days, this year particularly, we shared those stories who were deported. We have a lot of migrant workers. People go to Gulf countries, and there, like, the two people were deported because of having diagnosed with LF after reaching there. And then motivation and individual counseling in special cases through doctors, medical persons, people having diabetes, and then hypertension, chronic heart disease, and kidney disease. All those chronic illnesses, we mobilize the doctors to let them know that even if you're taking the chronic disease illness, but no, I'm taking the MDA drug. So there are some municipalities who have introduced MDA card for those who come to booth or who take the medicine during campaign. They are given MDA card, and then they have made it compulsory to get any other service from that particular municipality. If they want to take any service, then they have to show the MDA card. That is really pushing people to go and take the medicine. And choose the suitable time for the drug distribution as per the local context. Sometimes morning, sometimes evening, sometimes late. Whenever we know that that person will be available, our facilitators or health workers go to visit that person on that time. So we can't expect everybody coming on our time. So we have to know which is their time where they can be available. And then mobilizing school teachers, female staffs in girls' madrasa and male staff in boys' madrasa. So we do that. And then sharing news story about deported migrant. Yeah, that I already did. So next, please. So I would like to share some of the fact and figures about what we achieved after using all this strategy, and then identifying never treatment population. So I have taken example of particularly from Kapil Vastu Lumbini, though other examples are from Kosi province, Jhapa district, but then more examples are from Kapil Vastu. So MDA coverage in on-risk community, example from Kapil Vastu. Okay, analysis of information collected through supervision coverage to among 200 hours. We did the analysis of those people who took those 200 household from selected 20 wards in the district. Like there are 10 municipalities. If each municipality we picked up, like 20, like all two persons randomly we selected. So the response is that while using this approach, 91% of those who have not taken has taken the medicine this time, and only 9% still missing, not taken. So next, please. The same example, the number of respondents, like who didn't take, who took. So we have categorized according to the ethnic group. So Dalit, and then Muslim, Madhesi, and Janjati, and Brahmin Kshetri. All these we have categorized. So mostly the Dalit people, they have 97, almost 98 people have taken, and then Muslim, they have almost 94 have taken. The lowest taken is Brahmin Kshetri, that is 82. Okay, and then proportion of MDA drug injection in on-risk groups. Persons with disability, we interviewed 12, and then 93% of those 12 have taken the medicine. School teachers, there were 3 people interviewed, all 3 took the medicine. Religious leader, 5 were interviewed, all 5 were took the medicine. And urban resident, 96%. Agriculture workers, 98. So like the, if you see this diagram, almost majority population, more than 90% of that particular group have taken the medicine when we use that kind of strategy. Okay, next. So we have taken also some example from our 4 districts where we supported Nepal government to carry out the MDA. So in Jhapa, that is in eastern region, 13th round, now after 13th round, now the first, that was like first round of IDA carried out, and 13th round that has been already done, and Morang 12th round, and Kapil Vastu 16th round, but it still is not achieved. The target is not achieved. So we got to repeat again, and Baglum, all those 3 other districts, we use the same approach to all. But okay, another please, another. Okay, another. Yeah, some glimpses of how we do the mass awareness. We also reach out to the traditional healers, the Orthodox religion, Hindus, and then yeah, all these mass awareness. Another, next. And this Muslim community, all Maulanas were gathered and given the training, given the orientation by Maulana itself. And then security force, the security force were also given orientation, and then we use this kind of public transport to go around. Next, please. So that is the person who is showing the MDA card, and this is the security person who was mobilized to distribute drug. So another. in the border area. Another, and reaching to during nighttime also we reached and distributed drugs. That is the picture about, and reaching to madrasa, and then also reaching to the maulanas. Those maulanas are taking the medicine. Another, please. Yeah, acknowledge. I have finished almost. So at last, I would like to acknowledge the leadership and collaborative efforts of Nepal government, particularly EDCD, Department of Health Service, Ministry of Health, province health authorities, municipality health workers, and female community health volunteers. We collaborated with them at every stage, and then this is the result. Next. Yeah, thank you. This is the last slide. I think I made up in time. Thank you.
Thank you so much, Nirmala. And I'm sure there's lots of questions that people are having as you've listened. So please do make a note of your questions or put them in the chat, and we're going to have time at the end for some discussions. So thank you so much, Nirmala. And I will give the floor to Rajshree.
Okay.
Morning and good evening, everybody, and wish you a very, very happy new year. Just wanted to check my slides are visible.
Yes, they are.
Okay, so thank you so much, iCHORD Group, for giving this opportunity to the PCI India team to share our experience working on never treated population. This is a real experiential journey which we would like to share. PCI India is an organization. We have been working in India for past 26 years. We work in 16 states, 184 districts, and we've been working with around 17 million population in the country. We are committed to transform lives of people at scale and solving complex problems, social issues, but then definitely working in partnership with government, private sectors, and development organizations. We are present in various states. We have offices in various states of the country. Let me switch on to what do we do in LF elimination program. So we are a proud partner of the Bill and Melinda Gates Foundation, and we support and assist Government of India Ministry of Health as a social mobilization partner, and we assist them at the national, state, district level. Since 2017, we've been supporting in 8 LF endemic states of the country, largely focusing on the mass drug administration. Um, we have been working in and around 200 districts which are LF endemic, and till now we have supported for the mobilization activities in these LF endemic districts. We have actually taken this 4L social mobilization approach because the canvas or the population whom we have to reach is very, very huge. Hence, this 4L social mobilization approach entails to leveraging all the existing platforms like schools, panchayats, colleges, women's self-help groups, linking with the key stakeholders, officials, and departments, layering the key messages and call for action on all the existing platforms and channels at all levels. So generally, when we say social mobilization, the understanding goal, the work will be happening largely at the community level. But then when we work, when we have to make this 4L social mobilization approach operationalize at optimum level, we have to work at all levels. And this is a figure which depicts like the work happens at the community level and till the policymakers also. So we work at the community level. We also work with the policymakers and also various departments, because we work with the existing platforms and channels, and these are all driven by the varied ministries. So our journey of never treated, working with the never treated communities, I will try to talk in these five categories: how we understood the never treated, how we worked on the data and profiling, what were the options which we explored to identify the never treated population, how we designed the interventions, and how is being integrated in the larger program. So our journey started in 2021 and 22, and thanks to Allison and the Global Task Force team, wherein the discussion was happening on systematic non-compliance oblique never treated. As part of our mobilization during the mass drug administration, we used to measure the effectiveness of social mobilization post MDA, and we were having the social mobilization assessment tool. We added specific questions in the existing mobilization assessment tool, and we gathered data from field. We started with 11 districts, but then as of now, we have data from 141 districts across 9 states of the country, and the respondents are 42,617. When we collected the data and when we analyzed, what did we see? We saw that around 16%, around 11.6% population were falling under the never treated category. Overall, the proportion was 11.6%, and this data is coming from the adult population. But we've also found that there are variations by states and also by districts. Within the state also, we saw that there were huge differences in the proportion of never treated. So when we got this data, how did we analyze and what we did with that? So when we looked at this data, we wanted to understand the key reasons from this data, and here is the key reasons which we found. And actually, when we got this detailing of never treated, we actually deep dived into it and tried to understand what are the key reasons for not consuming the antifilarial drugs. And we found that if I look at the first key three reasons, it was coming out to be: I don't have filaria, hence I have never consumed; lack of trust on the drugs and also on the system, and also fear of side effects. There were other reasons also. While we were looking at these reasons, at the same time, with again support of the Global Task Force team, my measurement team, we actually analyzed the data and did a profiling based on the multi-level binary logistic regression, and we found that these are the specific groups wherein the never treated was depicting high. So it was higher among males, it was higher among the age group of 18 to 25 years, and you see this is a productive age group. Higher among the marginalized communities, largely when we saw it was among the Muslim communities, higher among the general caste and highly educated communities, higher among the people with myths and misconceptions, which was linked with transmission of LF, and also it was higher among the urban residents. Now, with this, we started working towards the solutioning part, because this gave us an insight where to focus and what to communicate, how to communicate. At the same time, we also got another very important insight on the prevalence. I'll just give an example. There's one state wherein we found at the state level the prevalence was 3.5%. So it's not that very huge. But then when we looked at the district, it was coming out to be 13.7%. But then we try to understand what is that level at the villages, and you see the level of NT or the prevalence of never treated population ranged from 2.2% to 38%. And that was a insight which we got, that if you have to work with the never treated population, the lowest unit is the village, or even go a little deeper down and see at the hamlets. But this was with this insight, we started looking at how do we identify, because these people are in the larger population, and hence we found that identifying the never treated is the key task if you have to work in the reduction of never treated population. So these are the four steps which we identified. If we have to really look at this prior to mass drug administration, it is very essential to enumerate the households prior to MDA, identify the never treated individuals, and here again we learned that it might be not that possible or not that productive to bring in the same health workers to identify the never treated. If we do so, it is very essential to give them huge confidence that it is okay if you get never treated in your area. Otherwise, the best option is to identify the non-health cadres, engage them in the enumeration exercise to identify the never treated. Once you identify, it is very essential to have customized oblique targeted communication so that they get motivated and mobilized to adhere to DOT, and then repeat the same process for the next MDA. Hence, the key takeaway is identification of never treated and targeted communication. That too, very customized, are the most important components if we are working with the never treated population. Let me share one example. How did we get into the solutioning? So, as I shared in my previous slide, one category during the profiling, we found that it is higher among the age group of 18 to 25 years. And hence, we got into engaging colleges and started motivating youth in the colleges for adhering to DOT. We designed a YES strategy, youth engagement strategy, and this we did in collaboration and partnership with Ministry of Youth, to keep in mind that these all interventions sustain in the system. So in under the Ministry of Youth, there is already existing system or existing volunteer scheme, which is NSS, and around 500,000 NSS volunteers exist in the across the country. We actually collaborated, partnered, and when I'm saying we, it is PCI who assisted the health program to collaborate with Ministry of Youth, and then we started working with the colleges, universities, high secondary schools, and so on. I will just share a data point wherein we assessed 182 colleges in February and August 2024 MDA round. And you see, dotted booths. So these are the booths which were organized in the college premises, and this is a number you see, around 54.3% students in February 21st said that they consumed the antifilarial drugs as DOT in the college premise, in the booth. Around 54% students, they again reported in August 24 that they consumed antifilarial drugs within the college premises. So these are different districts per se, but the rounds are different. One is February 24 round and one is August 24 round. If we look at the never treated youth, I would say, look at the green box. It says one time. So, 9.8% students, they said never consume. But again, if you see, I mean, this is the I would say, ray of hope. If we target through the colleges, at least these students, they are consuming or adhering to DOT or consuming antifilarial drugs. And this is one example from the profiling till the solutioning. This is how we have been working on the with the never treated population. But then, if we do this, it is not the solution because there are many districts which are LF endemic. Hence, it is very important to do the scale up of intervention. While we were doing the scale up, we found that PCI as an organization is already mandated to do the refusal conversion during MDAs or the hesitant individuals and families. So instead of going with the notion of never treated, we actually made it through refusals or hesitant, convincing the refusals and hesitants. If I can share this data point, in 2024, during the February and August MDA round, we were able to convince 157,546 refusals to adhere to DOT. While we analyzed the data, this striking number came up, which said that of these refusals, 60% were falling under the never treated. And there we got the pathway. If we keep on focusing on the refusals, we are anyway working with the never treated categories. And hence we started working again, getting deep dived into refusals. And then we found that what were the key reasons. These are the 9 key reasons which has been captured as part of the experience coming from the convincing of these refusals. Now, these reasons, basis these reasons, we have actually developed very, very targeted, reason wise, specific way of dealing with these reasons, specific communication for drug administrators and supervisors. Now, with the program support, we are getting into building the skill of supervisors and drug administrators, focusing on refusals oblique hesitance, but indirectly working towards the never treated. Also, I'm very happy to share that the data on never treated, which was collected by PCI till 2023, now it has been integrated in the program through the WHO monitoring mechanism, and now it is scaled up. The never treated data is coming through the system, and then we are working on the skill building of drug administrators and supervisors so that these people can be convinced to adhere to DOT. So this is about the story and journey which we have undergone till now with never treated. I would like to give a special thanks to the program National Center for Vector-Borne Disease Control, the colleagues and team, Bill and Melinda Gates Foundation, Global Task Force, and colleagues in iCHORDS. Thank you very much, and I'll be happy to take the questions. Thank you so much.
Thank you, and we'll pass to Aya.
So thank you very much, Nirmala and Rajshree, for very interesting presentation. And I'd like to ask everyone in the audience to put your questions in the chat box, so because we have 20 minutes for the Q&A. So I would like to start with the first question that I can see in the chat box. So the first question goes to Nirmala. So thanks again for the great presentation. So if you have to choose 1 or 2 intervention, which do you think was the most effective at reaching the most people?
Yeah, thank you. It's a Molly question, I guess. Yeah, it's so difficult question because we definitely need to apply multiple actions. Single action doesn't work. But still, if you want me to prioritize, I would prioritize 2. That is identifying who are the never treated population and where are they, and then mass awareness in targeted areas where the never treated population are there, and targeted message, as Rajshree already said, targeted area and targeted message with mass awareness. Those two I would like to take. Thank you.
Thank you. Maybe I will ask the same question to Rajshree as well.
Dr. Aya, I would say identification is very, very important, and that's the key challenge, because these never treated, they are in the larger population, and hence preparing before identification of these population prior to MDA is very, very important. And the second thing which I will very strongly recommend is the skill building of the frontline workers and their supervisors. I think in the country program, the supervisors really require a hand holding. So identifying and skill building of these frontline workers will definitely make a very win-win strategy.
Yeah, that's also a very interesting point, because I think the community worker and the drug distributor, they really have to be confident themselves first, right, to convince others. So that's a very important, but often difficult things to do in the field, I think. So the next question is again to Rajshree. Very interesting about this connection with the Ministry of the Youth. And can you talk about how they have been engaged?
So thank you for the question. We work, so right from the beginning, our understanding was everything which we do should sustain. And hence we wanted to look at those ministries who have last mile connectivity. And hence we have worked with the Ministry of Higher Education, Youth and Sports, and Rural Development and Panchayat. All these ministries have last mile connectivity. I gave example of working with Youth Ministry. So we work at the national level. The Health Ministry and the Ministry of Youth, they converge. There are meetings and dialogue and intervention, which is a challenging thing, but we are very happy to share that the National Center for Vector-Borne Disease is very open for collaboration, and they have collaborated, and the advisory goes from national level till state level to district level and to the institutions. And we play the facilitating role, wherein we bring the NSS coordinators or officers and we capacitate them, motivate them, show them the data that, see, of your so many students, 50% have consumed for the first time, that too at this age, whereas the program has been going on for long. So those data points actually gives them a trigger to think, and that is how they collaborate.
Thank you. I think it's a successful case of involving other ministries for the MDA. And now the next question is for Nirmala. So how was the MDA at nighttime operationalized? And this would be a good option for many sites. So wondering how this worked.
Yeah, actually, there were practice of leaving the medicine at home during a home visit or during the campaign day. And then because people, especially men, they go out, and also women, they go somewhere along the border side. So leaving the medicine at home to expecting that they will come back and take, that didn't work out. That gave false coverage, and then the disease was never controlled. So what we try to do is now, if we try to find out if the certain people are absent during daytime, we ask what time they return back from labor or from anywhere. Then they say, yeah, this time. So our field workers or also the government health workers are motivated to go to visit during the night time and ensure that they ingest the medicine. So it is very important if we really want to increase the coverage in a real sense.
Thank you. And also in a similar line, one more question to Nirmala. So you mentioned also, the security personnel, like security guards, were also involved in the drug distribution. And could that have created any like a fear among the people since they are like, the act as an enforcer? How was the reaction? How was feasible for this approach?
No, actually, we discovered that the security persons were also not taking the medicine. They were left out. And then later, when we oriented them and they started taking, and then because they are in the border policing and people keep going, coming, and then we motivated them to also make sure that those people who have mobility across the border should be also taking the medicine. So we mobilize them. So as I said, we mobilize a lot of various type of influential people. Security force are one of those influential. And then there was no, it's not like people were fearful of security person, but security were convincing them. If somebody is crossing the border, somebody is crossing in the border, inside, they were taking, please take it, and they were taking.
Thank you. Actually, I remember, some of the Pacific Island countries, they were also sometimes using the police and even army to the supervise the MD activity. Sometimes it's also necessary, right? So then another question to Rajshree. It's interesting that you mentioned that alcohol use as a key reason for refusal or never treatment. And so this person also have encountered similar finding in their studies for oncocytic and LS. So how did you handle or address this in your work?
So we've not overcome. We are still working on that. So it is this whole refusal, the 9 categories which you saw on the slide, is the work of around 2 to 3 years, I would say. Round by round, we kept on identifying the reasons, and then we actually worked with 121 specific cases and brought in the reasons. So these alcoholism came as a challenge from certain geography. So it happens so largely male. They work throughout the day, and the evening they will get into groups and they will drink. And so we, from one side, we are pushing the drug administrators that during the day males are not there, so go in the evening. But then during the evening you find this male like happily drinking and kind of bullying the health workers, like, oh, she is from my own village and she's become now doctor and she is now supplying medicines to us. So we had a very good debate internally, and we thought that there could be 2 possibilities. One is like not get the health workers' life difficult, um, take some influencers, generally male, from the community, and then prepare them so that at least next day they are ready to consume. But during that hour, we are not pushing the health workers to interact and deal with them. So that's a very practical solution which we have come up with.
Thank you. And also, you mentioned that one of the main findings was the lack of trust. And so you mean the lack of trust from the community to the healthcare worker. Is that right?
So it was 2 ways. It is one is like lack of trust on the system. So a few community members in that 121 cases, they said that because when I went to with my child, when the child was sick, I did not get any support. But now you're sending drugs, so there's some problem. So it's kind of suspicious about the antifilarial drugs. Again, it is due to lack of sufficient, accurate, and complete information. So that is one of the reasons which had come in the whole process.
Okay, and maybe something also related to that one, maybe no, but I also have a question. So, for the Nirmala's presentation, there was a different reason for the refusal or never treatment. not receiving the treatment. But then I didn't see any, the point where you say, they said the community drug distributor didn't come to provide the medicine. But in Rajshree's, the presentation, I saw like in one of the factors, actually 12%, more than 12% responded that the drug distributor didn't visit them. And also there was another one, never received drug, and it was also 10%, so maybe more or less similar. So meaning more than 10%, maybe up to 20% people actually didn't receive the visit of the drug administrator, right? So this means you really have to also engage, but both your presentation really focus on how to engage the community better. So did you have any intervention? How do you motivate or make sure the drug distributor do their job? And was there any way to even monitor them?
Yeah, actually, earlier there were those cases few years back. Until few years back, there were those cases. That's why it's very important to identify who are not taking the medicine and why are they not taking the medicine. So after we understand this, then we also motivate the health workers and health volunteers so much, and we ourselves are there with them. We don't leave only them. So we make sure that our team is heavily mobilized along with the government team. So they past 2 years, like since we started identifying the never treated population and the region, we have not heard about that, like health workers didn't come, because the whole purpose of our identifying never treated population is to give them access to the drugs. So it's working. It's working. It's quite a lot efforts, 2 months efforts. Nobody does any other work, but we only focus on that in that area. And I also talk about districts where we have supported the Nepal government, 4 districts. But Nepal government also does other, like other RTI and other organizations also support. But then I'm not aware about that issue anymore.
Okay, that is good. Yeah, I am aware also that in Nepal, the last MGA, everybody really put an energy to, improve the coverage. So there is also, I think that Rajshree's dropped in the connection. I hope she will be back soon again. So in the meanwhile, one question here, was there any severe adverse event during MGA or after MGA? Because such event often create a fear and not taking MGA. Was there any event like that in Nepal?
Yeah, it was one event in Japa this year, like in 24, that coincidentally one woman, after taking the LF drug, she died suddenly. And then that was a huge, challenge. And luckily, WHO colleagues were there, and we were there, and Nepal government persons, from EDCT were also there. So we handled that case because it was tested and all, and then it was finally found out that MDA drug was not the cause of her death. Because she was taking some, she was having some chronic illness, and something was already wrong, but then that only became the coincidence. Yeah, what we
Thank you.
managed, everybody managed.
Yeah, I remember we also supported
Yeah.
the very
Yeah.
rapid communication,
Yes.
the press release and all that to
Yeah,
make sure
yeah,
that
yeah.
communities are not affected. Let me check another question. Okay, thank you, Rajshree, for coming back. So I now have one question for you. So you mentioned the targeted, the messaging for the different, the population group. So how does the messaging change for youth and adolescents? And can you share like some additional detail about the youth engagement strategy that you had in your presentation?
So for a general community, we have a larger communication toolkit, which flows from again NCVBDC till the last level. But then when we go to the colleges or when we interact with the youth, we talk largely on the risk, because until unless they are very much aware about the risk, they might not be able to understand why they should consume. Largely, if you see, one of the key reasons which come is they say, I don't have filaria. They perceive themselves healthy, and hence we focus on two very important things. For largely the boys, we focus on hydrocele. What is the risk of hydrocele and what is its implication? And the second part which we work on the youth is to make it more aspirational, in the sense, if you have to get into some career wherein you have to run, you have to take heavy workload, then you might not be able to do if you get into this particular disease. So this is how we work with the partner who works on the communication piece, and these are two things which we focus on the while interacting with the youth.
Thank you. I think the similar comments are in the chat, for the sharing experience from our state coordinator, right? So the one of the biggest, reason was that they think, especially youth, I guess, think they don't have disease, so why do I have to take it? So you really have to communicate them on the really good effect of taking this medicine.
Yeah, I just wanted to add one,
Yes.
That's why we are also mobilizing the LF affected persons who are so motivated to prevent from, to save others from getting the disease. So that has been very effective, because they go and say, look, if you don't take the medicine, you will be in my situation. And there is no way that you can cure, so that kind of, they give that kind of information, and then they go to all their nearby locality, and that has been also quite motivating to others, convincing others.
Yeah. I think, the involvement of the people affected by LF is really the very important present. We are really thankful for those who really are helping for the campaign. And I think it's a very powerful, the intervention to engage the communities. Maybe the last question again to Rajshree, maybe it was also in your presentation, but just to reiterate, how often fear of side effect was the reason for being never treated in India?
So, fear of side effect, I think people generally do not say very specifically. But then, while we were doing the deep dive on reasons for refusal, we found that there are three scenarios. One is, I got headache, I got fever. The second is, I saw somebody getting fever, somebody getting dizziness. I heard somebody getting fever, somebody getting dizziness. So these are like three very specific reasons which people say. It's like self, hearing, and seeing somebody else experiencing. So it comes, and it is coming as fear of side effects is coming as 14% in the data which I just shared. So
Relatively
dealing
high.
with it is very, very different. And again, I will reiterate, capacitating our drug administrators and the supervisors is so very important. And then also giving them the confidence that seek support from the influencers, seek support from teachers, seek support from the women self-help group leaders. That is still one area which they will have to actually improve and learn more to do.
Thank you very much. So thank you very much again for Nirmala and Rajshree for the excellent presentation and facilitating Q&A. So I will hand over the floor to Varsa. Thank you.